Hi everyone, my name is Jamie George and I'm a PGY2 ambulatory care pharmacy resident at Henry Ford Hospital. Today I'll be talking to you a little bit about allergic rhinitis. By the end of today's presentation, you'll be able to describe the anatomy and physiology of the upper respiratory tract, identify the signs, symptoms, and complications of allergic rhinitis, evaluate if a patient is a candidate for self-treatment, discuss the treatment options for allergic rhinitis, and counsel patients on self-treatment of allergic rhinitis. With allergic rhinitis, there's a substantial burden associated with it, and it's multifactorial. The prevalence of those diagnosed with allergic rhinitis in the U.S. alone is 14% of adults and 13% of children. There's a couple different adverse consequences of the condition, so it might include impairment in physical and social functioning, daytime somnolence and fatigue, irritability, depression, attention deficit, among others. Not only do they affect the quality of life of patients, but they also have a twofold increase in medication costs compared to those who don't have allergic rhinitis. Direct health expenditures can total up to $2 to $5 billion annually, but that's not including the indirect costs like missing work as well. Now, what exactly is allergic rhinitis? It's defined as an immunoglobulin E, or IgE, mediated inflammatory response of nasal mucous membranes after being exposed to inhaled allergens. So what happens is that the nose performs air conditioning functions to help prepare those gases that are being breathed in and prepare those and the contents of the gases for the lungs. These functions include heating, humidification, and cleaning. However, the cleaning process can lead to allergic rhinitis. Both sympathetic and parasympathetic stimulation occurs in the vascular tissue in the nose. So the stimulation of sympathetic fibers causes vasoconstriction, reduction in tissue size, and airway widening. Parasympathetic stimulation leads to vasodilation, increase in tissue size, and airway narrowing. The nasal mucosa contains many different cells, including mast cells, which I'll get into. Knowing this, we can understand how the body's immune response to allergens leads to allergic rhinitis. There are early and late phase reactions known as the allergic cascade. There are several mediators, which includes histamine, cytokines, and leukotrienes, which all come together. Typically, the allergic cascade starts with sensitization to an allergen, and then the body produces IgE specifically for that allergen. We don't see an allergic reaction right at that moment, but when the patient is re-exposed to that allergen, that's when an early phase response is triggered, and we see that response within minutes to an hour. At that time, the IgE from mast cells binds to the allergen and starts cross-linking with the IgE. This eventually causes the mast cells to explode with histamine, and the other inflammatory mediators are shown here in the image. And they all come together, and this is when the symptoms start off. We see itching, sneezing, rhinorrhea, nasal congestion. All of that happened with this allergic response. Next, there's a late phase response that can occur after 3 to 10 hours. It occurs in about half the patients. What happens is eosinophils secrete substances that increase inflammation, and those are drawn in other immune cells. They draw in other immune cells to perpetuate the inflammatory response, which is like a second wave of mediators. This results in a profound inflammation, and we get a hyperresponsive mucosa. This is likely responsible for the patients who have the chronic symptoms that occur. So as I said, this happens in about 50% of those patients. In patients with allergic rhinitis, as I said, we see sneezing, rhinorrhea, and itching eyes. It happens in both nostrils, and it's usually worse when they wake up. Throughout the day, we see it sometimes improve and then get worse again at night. We also see patients that complain of postnasal drip, cough, irritability, and fatigue. And depending on the patient, it can occur year-round or seasonally. Here you can see some of the hallmark facial features. So the Denny's lines that are shown here under the eyes, that occurs due to all the rubbing and the squinting. The eyes are puffy and irritated all the time, so we also see the allergic shiners often, and those look like a light black eye. Since patients are rubbing their nose a lot, they often have an allergic crease as well. Allergic rhinitis can be classified by temporal pattern, frequency, and duration of symptoms, as well as severity. To categorize them by temporal patterns, we have to understand the time of the year and the context of the exposure in which their events are occurring. Perennial rhinitis is when it occurs all year round. It can be caused by dust mites, mold, and pets. Seasonal rhinitis is usually just from plant pollens. More specifically, we see ragweed, tree pollens, and grass as those causes. We also have episodic rhinitis from allergens not normally encountered, such as visiting a home with pets that the individual typically doesn't encounter in their own home. The other way to classify allergic rhinitis is by frequency and then by severity. So this table here is important to remember since it guides our treatment, knowing how the patients are classified. Based on how many days per week and weeks per year, we can classify if they're intermittent or persistent. So for intermittent, they must have symptoms for 1 to 4 days per week or 4 or less weeks per year. Note that for persistent, their symptoms are present 5 to 7 days per week and more than 4 weeks per year. So for intermittent, it's either or, and then for persistent, they must have both of those present. Based on frequency, then we can classify severity as mild or moderate to severe. Mild symptoms don't interfere with quality of life as opposed to moderate to severe. And if a patient seeking treatment, they're usually in the moderate to severe category. Now to treat patients, we have a few options. We can go to the non-pharmacologic way of controlling the environment to avoid allergens, incorporate pharmacologic therapy, or utilize allergen immunotherapy. It is important to use environmental controls. We can treat them as much as we want, but if the patient is continually exposed, the treatment won't really be that effective. So we have to try and lessen that effect. For this exam, you're going to be responsible for knowing the environmental control and the pharmacologic therapy side of it. So we'll be focusing specifically on over-the-counter treatment, so you don't really need to know those prescription medications and the immunotherapy section for the exam. Patient education is also an important area for you to focus on. It's critical to know this, especially for administering non-prescription medications for children. The environmental control we're going to use in patients depends on their allergen. So on this slide, you can see some of the techniques to remove each type of allergen. For house dust mites, you can lower household humidity to 40% or less, or apply acaricides. If there's carpet, that should be removed. Furniture should be upholstered. Stuffed animals should be removed. And dusty bookshelves have to be cleaned. Mattress should be encased in mite impermeable materials, or else the bedding should be washed in hot water, so 130 degrees Fahrenheit, at least weekly. For pets, the most effective way is to remove them from either the bedroom or the home. Understandably, that's not always an option, so another way is to make sure the pet's being washed at least 1 to 2 times weekly. For other allergens, think of what could reduce the amount of allergen in order to have an idea of how to remove them. So, for example, for pollen, we want patients to avoid being outdoors during the times when there's a lot of high pollen count. For mold, we want to make sure there's not too much humidity inside, so reducing the indoor humidity to less than 40% is really effective because we're going to be able to reduce the moisture and from that minimize mold. Cigarette smoke should be avoided for those who are triggered from smoke as well. All these control measures will help in reducing the allergen level, but there might not be evidence that it'll reduce symptoms. Only 3 of these controls will reduce symptoms, as you can see on the right side of the table. So removal of pets, acaricides to kill dust mites, and combined use of multiple control measures. What that means is that no matter how much you wash the pets, it's not going to help much unless you actually remove them. Overall, the amount of exposure doesn't matter since you're still being exposed to the allergen and will thus be experiencing symptoms. It's important to know this exclusion criteria so that you know if they have to be referred to the primary care doctor or not. If we recommend any patients that fall under this criteria, we're basically practicing out of our scope. So the first exclusion criteria is that if they are less than 12 years old, they can't self-treat. The only exception is if the provider has already diagnosed them and recommended them to have an over-the-counter medication. But they need to be evaluated by the primary care provider because it could be something different since certain conditions can result in rhinitis without an allergen. Those who are pregnant or lactating should receive treatment recommendations through their provider. Those with symptoms of non-allergic rhinitis or signs of an infection are also not candidates for self-treatment. Those with respiratory disorders like asthma or COPD should also see their PCP first. If they have uncontrolled asthma, this can make their allergies worse because allergies and asthma usually go hand in hand. History of side effects with over-the-counter medications is also another reason why they can't self-treat. So make sure you know the slide for the exam. You'll have to make sure for each question or for each case that the patient qualifies for self-treatment before recommending an over-the-counter medication. Once we know that they're self-treatment candidates, we can recommend pharmacologic therapies for them. If we know that a trigger is coming, like a certain month of the year when season starts, it's recommended to start taking the medication 1 week before the expected exposure. There are some patients who do remain on medications year-round, though, especially for those who have chronic symptoms. For those who don't need medications all year, though, they should be on the medications for the least amount of time to help them and not hurt them. There are several options available. So intranasal corticosteroids like Flonase are typically the first line option. Antihistamines like Claritin and Allegra are commonly used pills. Mast cell stabilizers like cromolyn, also known as nasal crom, are useful since the mast cells are present in the nose, and those are what help release the histamine and other inflammatory mediators like we said. Combination products like Claritin D, Allegra D, what they do is combine antihistamines and systemic decongestants. Sometimes it might be cheaper than buying them separately, but we really don't want patients to be on extra meds than they need to be. So we definitely want to recommend that if they can be controlled just on an oral antihistamine without the decongestant combined, that's the best route. So it's best to minimize the decongestants, mainly because of their side effects as well. Leukotriene receptor antagonists help to reduce the inflammatory response, but they're only prescription. Here are the guideline recommendations for different therapies. So the plus symbol, that's associated with the effectiveness of the class with each category. Intranasal steroids are the most effective for symptoms and also effective for temporal patterns, symptom frequency, and severity. Oral antihistamines don't have as much of an effect. They're not as effective, and there's no recommendation for use with severe symptoms, as you can see. The patient preference for all the agents is pretty good, except for the leukotriene receptor antagonists, which, as I said, those are prescription medications, so it's not a focus for today's presentation. The intranasal corticosteroids are currently the first-line treatment option. They are currently all over the counter, and the products are Nasacort, also known as triamcinolone, Flonase, known as fluticasone, and Rhinocort, known as budesonide. Randomized controlled trials have shown that there's more benefit than harm with these medications, and monotherapy is recommended. Combination therapy can be used in those who have moderate to severe symptoms, and they can control allergic rhinitis symptoms pretty effectively. Since it's a nasal spray, there is minimal systemic absorption. It only gets absorbed into the nasal tissue, and it helps to control allergic rhinitis. For symptom control, it may take a full week before the symptom control kicks in, so that should be kept in mind when patients need something for immediate relief. It may take a while before it starts working, especially to see the full effect. That would take a couple weeks. There are side effects associated with the class, so that includes nasal discomfort, bleeding or sneezing, and increased risk of infection. It's important that they know to make sure their nose is moistened since it can start drying out after a while. Though when we use systemic corticosteroids, we can see growth inhibition in children, this isn't really seen when we use these intranasal medications. So they still are corticosteroids, but since it's really localized only to the intranasal route, there's low systemic bioavailability, and that's why we have less of a chance to cause growth suppression. Children, it's important that the medication is approved for that specific age. Nasacort is approved for years 2 and up, Flonase for 4 years and up, and Rhinocort only for those who are 6 years and older. For younger children, we typically use 1 spray for each nostrils, and for the older ages and for adults, we get to a higher number of sprays, so maybe 2 to 4 sprays per nostril. Again, make sure you remember what age each medication is approved for. It's also important to be aware of the brand names of these medications since they do come across pretty frequently. Here are some counseling points for the intranasal medications. Specifically for the intranasal corticosteroids, focus on the nasal spray section, and that shows how to use the spray. In counseling patients, we really want to make sure that they're using it correctly. Otherwise, it goes down to the throat. It's not really working effectively for them, so it's just wasting the medication. The nose that's not receiving the medication, basically what you need to do is hold that down. The tip of the spray should be pointed away from the nasal septum to prevent damage. And while you're pressing down on the pump, the patient should start breathing in through the nose deeply. After spraying, they should breathe through the mouth for a couple minutes just to make sure that the spray doesn't come right back out. It's important that they prime the pump as well before using it the first time. So they should spray it until they see that medication is coming out. Antihistamines are commonly used, but they're not the most effective for symptoms. It's indicated for symptom relief though, and there are many different formulations and different medications. Between the first and second generation, there's also important to know that there's a difference in the penetration across the blood-brain barrier, which is why we see a difference in side effects for both generations. So the first generation is non-selective in sedating because the medication can cross that barrier. This includes medications like diphenhydramine, also known as Benadryl, and also chlorpheniramine. Second generation medications aren't as sedating. The only exception is cetirizine, also known as Zyrtec. That has a worse side effect profile and is the most sedating out of the other second generation medications. The other ones in the class are like Claritin and Allegra, and they have a smaller adverse effect profile. The adverse effects are what you would expect from an anticholinergic agent, so it can cause dryness in the mouth, eyes, and nose. It can also cause blurry vision, constipation, and sedation. To better understand the efficacy and safety of the antihistamines, here's a table that compares the relative adverse effect profiles and the anticholinergic effects. Diphenhydramine is definitely going to work the best, but remember it has the most sedating effect when comparing to other antihistamines. The anticholinergics are used to reduce cholinergic pathway. Here you can see that cetirizine and levocetirizine have low to moderate sedative effect, but have the same anticholinergic effect as the other second generation medications, like loratadine. For the common OTC medications used, know which ones are sedating and which ones are not, especially for the exam. This table is a summary of evidence that shows what these antihistamines are indicated for. So these are the major medications that are typically used along with their usual dose and what they've been proven effective against. For example, fexofenadine and olopatadine nasal spray, there's not enough evidence for using against chronic or year-long allergies. Azolastine and olopatadine can't be used for treating hives since they're nasal sprays. And overall, just remember that intranasal steroids are the first line options usually. Here are all the oral second generation antihistamines. The contraindication for all of them include having a history of hypersensitivity to that medication. Also note the age that these medications are approved for. So cetirizine and cesiloratadine are approved for 6 months or more, while the others are only for children that are 2 years or older. Sedation can occur with cetirizine, but the other ones have less of a chance of that occurring. Though you don't really need to know the specifics for dosing, it's always good to have a general idea of that range. Patients should be on something that's really going to control their symptoms. So when we compare first versus second generation, like I mentioned, first generation is going to be the most effective. Diphenhydramine is more effective than chlorpheniramine, but chlorpheniramine is less sedating. For the second generation medications, loratadine and desloratadine have an equal effectiveness. If those don't work, we go on to cetirizine or fexofenadine. However, patients usually state that they've tried all of them and maybe one of them works better than the others. So each patient might have a different response. It's always important to kind of individualize based on what they've said their medication history is and what works best for them in the past. Cetirizine or Zyrtec has a fastest onset compared to the other antihistamines. With drug interactions, we worry about fexofenadine really though, due to the decreased absorption from PGP interaction. Cost is also a factor to consider when we're understanding the patient's preferences. This table here shows the difference in cost between brand versus generic antihistamines and comparing the different products with each other. Out of the second generation antihistamines and the generic ones, loratadine is the cheapest and fexofenadine is the most expensive since it was more recently released. Here's a table of the different intranasal medications. You don't need to know all of these. Definitely know the ones that are on the top 200 list that you have been provided. But just have a general idea of which medications fall under each class. Specifically under corticosteroids, remember that fluticasone, triamcinolone, and budesonide are used. Those are indicated for allergic rhinitis and prevention of nasal polyps. For the anticholinergics, we just have one intranasal medication, which is Atrovent, also known as ipratropium, which is indicated for severe rhinorrhea, congestion, and sneezing in children. We don't see that used too much. Antihistamine-wise, for intranasal medications, we have azelastine and olopatadine, used for seasonal allergic rhinitis. For intranasal decongestants, Afrin is the only product available in the U.S., also known as oxymetazoline, used for nasal congestion. And then finally, we have combination intranasal medications like Dymista, which combines azelastine and fluticasone. And this is also used for seasonal allergic rhinitis. Another class of medications, as I mentioned before, is the leukotriene receptor antagonist. This is a prescription medication. These medications inhibit the cysteine leukotriene receptor, which is one of the inflammatory mediators that the mast cell releases. So both montelukast and zefirlukast are in this class, but only montelukast, also known as singular, is used for allergic rhinitis. They're generally used for asthma. It's used for those with perennial allergic rhinitis, and it can be used in children 6 months or older. However, if it's specifically for seasonal allergic rhinitis, it should only be used for those who are 2 years and older. When they studied these medications, they found out it wasn't as effective as intranasal corticosteroids, but it was similar in effectiveness to antihistamines. When they added it to the intranasal corticosteroids, there was not really a change compared to the monotherapy, but when they combined it with antihistamines, the combination therapy was more effective. One thing to note about this medication is that it's been particularly effective in those patients that have asthma and also have allergic rhinitis. So, as I said, it has indication to use for both asthma and allergic rhinitis. Cromolyn, also known as nasal crom, is a mast cell stabilizer, which, as we know, is the cell that's releasing inflammatory mediators like histamine. It inhibits degranulation of the mast cells, which is the process that would release histamine and those mediators from the cells. This is also a nasal spray. It can be used up to 6 times in a day. Similar to other medications that are used for seasonal allergies, remember it's most effective if they're using it 1 week before being exposed to an allergen, especially because it can take up to 7 days before you start seeing any efficacy. Even though it's safe to use, it doesn't really help patients that much, and it can take a long time to start working. So definitely something to consider when patients ask about it. Finally, for certain patients, we can also consider immunotherapy. It's not considered all the time. The idea behind this therapy is to inject small amounts of the allergens continuously to help patients. It helps them develop their immune system so they don't really react as much when they're exposed to an allergen. These are allergy shots that are provided by the clinicians at the office. We see this used in patients who've tried all these therapies, they're not really responding to the usual treatments, and also those who have issues tolerating any therapies, like having any hypersensitivity to them, and also those who don't want to be on medications long term. Additionally, if they have allergic asthma, we don't want to use this immunotherapy in those patients either. Some other less commonly used treatment options include inferior turbinate reduction, where they go in and they cut down the tissue to reduce the amount on the lateral wall of the nose, so it's not going to respond to the allergens as much. Another is acupuncture, which has shown to offer some symptomatic control and also improve patients' quality of life. For herbal therapy, there's not really any high-quality studies available that value efficacy and safety. Ephedra is one of the herbal medications that has actually been banned since it's been associated with severe side effects, so it's been shown to cause heart attack and stroke. One of the more common treatments that are available are nasal saline irrigation, so you might have heard of neti pot or something similar, like those rinses that have been used. This is the image on the right. Patients who don't want to use medications may try this first. Knowing which scenario a medication is preferred and an idea of how long it's going to take to work is really important to remember, especially for your exam. There may be more than one first-line option for a patient, but they might need something that gives them fast relief, so keep that in mind because that's crucial. If they're complaining of congestion, we typically give them an intranasal corticosteroid first. It's not wrong to give them a decongestant, but the best option is an intranasal corticosteroid, especially because of the side effects that we can get from decongestants. But if they do need fast onset, then we give a decongestant, especially an intranasal spray like oxymetazoline. It provides relief within minutes, but it shouldn't be used more than 3 days because it can actually cause rebound congestion. So just remember, if they need something fast for congestion, intranasal sprays will be the best, but it shouldn't be used too long. It's important to also know which types of symptoms they're having. So if they're complaining of sneezing, itching, or rhinorrhea, then it's more appropriate to give them an antihistamine. We typically use oral antihistamines first, like Claritin or Zyrtec, but there's also intranasal antihistamines, like azelastine that I mentioned, that are available. If there's mild symptoms, we usually stick to antihistamines, but if there are moderate and severe symptoms, intranasal corticosteroids are preferred. Sometimes based on if they need something to work quick, you can try to have them start an oral antihistamine along with an intranasal corticosteroid. So they might overlap for our first few days until the intranasal corticosteroid kicks in. So this is a common combination that we see used even in younger children, since the intranasal corticosteroids can take about 2 weeks until that full effect is seen. If they're rejecting all medications and prefer complementary medicine, acupuncture, as I mentioned, is available, but there is limited evidence around it. Now that we've talked about allergic rhinitis, different therapies that are used, let's go through some cases so we can apply this information we discussed. SM is a 31-year-old female who comes to your pharmacy with a chief complaint of red, watery eyes, constant sneezing, and a runny nose. She states her symptoms began a few weeks ago around the time when spring started. So, upon further questioning, you find out SM's symptoms are the worst in the mornings, right after she opens the windows to let the air in. Now let's go through a few questions. What is likely causing SM symptoms? So the cause here might be due to pollen. It sounds like it's a seasonal allergic rhinitis that started right when spring began. Upon further questioning, you also found out that it's worse in the mornings, right when she opens the windows to let the air in. Can she self-treat? So yes, she is old enough and not in the exclusion criteria. She's 31 years old. As long as she's not pregnant, then she is able to use something over the counter and self-treat. Now, what are some non-pharmacological methods SM can utilize to improve her symptoms? The best way is to keep the windows closed and also to avoid outdoor activities, because when those pollen counts are high, that's when patients have the worst symptoms. So making sure that they're avoiding the outdoors when that occurs is crucial. What are some pharmacologic options for treating LA? So she's experiencing moderate to severe symptoms. Because of this, you can use intranasal corticosteroids or antihistamines and even combination therapy. Out of those options, which of those is going to be the best? So the best option for her will be to use an inhaled corticosteroid like Flonase or Nasacort. If they want something fast, they can take an oral antihistamine for the first few days along with the intranasal corticosteroid, since it takes 1 to 2 weeks to start kicking in. But generally we want them to be on an intranasal corticosteroid. Let's move on to the next patient. CM is a 70-year-old male who comes to your counter with a box of Benadryl and a box of Claritin. She asks you what the side effects are associated with each drug. How should you respond, and which one would you recommend for CM? So both drugs have anticholinergic side effects since they're antihistamines. You can tell her that she can experience dry mouth, dry eyes, and dry nose. She can also experience more blurred vision, constipation, urinary retention, sedation, and tachycardia. The difference is that second-generation medications like Claritin, also known as loratadine, will be less likely to cause those side effects compared to Benadryl. For patients who are elderly, we typically also want to avoid Benadryl since it's on the Beers list. There's concern for elderly patients if they develop confusion, sedation, and the anticholinergic effects, which is why it's on the Beers list. To respond to her, you can tell her that they work similarly. Even though Benadryl might work a little better, it can cause her to be a little tired. They also don't recommend for it to be used in patients who are older than 65 years old, so you can recommend that Claritin is used for her and review the side effects with her. You can also tell her there are other options we can try if she's having issues tolerating the Claritin. So we would like her to try Claritin first, and then we can also mention other second generation antihistamines if she comes back and it's not really working for her. So now for our last case, YH is a 5-year-old child who comes to the pharmacy with his mother. His mom states that his physician recently diagnosed the child with allergic rhinitis. She also heard about a medication called Singulair and wanted to see if this could be an option for YH. How do you respond? So first off, Singulair is a prescription medication, so she would have to discuss with her physician about prescribing it. You can tell her that it's not as effective and not more effective than the over-the-counter medications. Though diagnosed, the provider should approve the over-the-counter medications used because they are less than 12 years old. Now, the next part is that the physician spoke with the YH's mother about using an intranasal corticosteroid. What options can you present to her, and what instructions should you leave with her? So Nasacort, which is approved for those who are 2 years and up, and Flonase, which is approved for 4 years and up, are different options that could be used. Depending on which product is chosen, you would want to provide her with the age-specific dosage. For both, it would be 1 spray for each nostril. You can also provide her with counseling on how to administer the intranasal medication, so refer to the slide that goes to the administration, since that comes across in the community side quite a bit. And obviously also make sure that she's aware of the side effects and what to watch out for. Alright, thank you for listening into this presentation. Please let me know if there are any questions. My email is on this slide, so you can reach out to me or to Amber with any questions.